This is Dr. Howard Strassler with a Hints from Howard, some restorative problem solvers. And today we're going to be looking at VPS impression materials. We're going to reimagine them, that they're going to be more than making impressions for our restorations, but that there are other uses that we can have for these materials. First of all, vinyl polysiloxane impression materials were introduced in the 1970s. But they can be used for more than just making impressions. Let's take a look. First of all, VPS are the most used impression material in dentistry today because of their physical properties: accuracy, good reproduction of detail, stability, high tear strength, recovery from deformation, and they're more easily visible when evaluating impressions. And besides that, the manufacturers give us many clinical choices: multi-viscosity, a variety of techniques for impression materials, low viscosity, medium viscosity, heavy viscosity, putty, tray materials. We also have control over working and setting times. Regular setting times and fast setting times make it a multiple use material for impressions. So with these VPS impression choices, you can pick the technique that works best in your hands. One of the extensions of VPS impression materials was the creation of occlusal registration bite registration materials. They're accurate, they're dimensionally stable, they're verifiable, they have unsurpassed accuracy and durability, especially when sending cases to the dental laboratory. But let's take a look beyond that. Let's look at VPS materials reimagined. And we're going to look at them using them as a matrix, a stent for provisional restorations, as a stent to evaluate prosthodontic preparation, reductions, and clearance. We can create stents, a matrix, for placing direct bonded aesthetic composite restorations. And finally, we can use it as a blockout when we're placing fiber reinforced splints and bridges for periodontal splinting, to create 3-unit bridges when we're placing implants, or for replacing missing teeth. So first, let's take a look at fabrication of bisacral provisional restorations for prosthodontics. This patient presented with a history of pain in the mandibular first molar when chewing, some diagnostic testing, and we determined there was a cracked distal lingual cusp. Treatment was to be a PFM crown, and the amalgam is intact and acceptable. We need to hold this tooth together. And so before we start the crown preparation, let's find a way to make that provisional restoration. We're going to use a bite impression tray, a triple tray, using some VPS impression material, and I typically use a fast setting medium viscosity, and I'm making an imprint of the unprepared tooth. This is going to be my matrix for placing my provisional restoration. I now do my crown preparation to completion. Now I'm ready to make my provisional restoration. I take my bisacral resin, auto-mixing, placed in the imprint. I reseat the carrier, verifying the same occlusal relationship as when the tray was not in place, and I leave it in place. The clock is ticking. The bite tray is kept in the mouth for between 75 and 90 seconds. Just follow the manufacturer's instructions. And when the time is up, I remove the tray from the mouth. The bisacral is still a little rubbery, and typically it comes off in the impression. The provisional restoration duplicates the contours, the anatomy of the original tooth. I have minimal adjustment, both to the proximal and the occlusion. Now I'm ready to make my impression, and then I can cement my temporary. I'm also using it for multiple units. I'm creating a VPS template, a stent, for these provisional restorations by making an impression of an aesthetic diagnostic wax-up from 7 to 10. I make an impression of the diagnostic wax-up, and then using the same technique, the bisacral, using an auto-mix tip, is placed in the number 7 to 10 imprints. I place it on the teeth. 75 to 90 seconds later, I remove it from the mouth, and the material comes out with the with the impression that I've made. I then do my adjustments. I'm using Softflex discs. I find them best for trimming at the gingival margins. I'm using a separating diamond to create my provisional restorations. But the proof is in the pudding. If I take a look at my preoperative view, my provisional restorations that were fabricated, and then my completed all-ceramic crowns, you can notice that diagnostic wax-up was critical and crucial for the fabrication of these aesthetic restorations by the dental laboratory. It takes significantly less time than when using some of the other monomer polymer-based temporary materials. I'm also using my VPS to create a matrix to guide my composite placement. For these two central incisors, 8 and 9, the patient's unhappy with the aesthetics. But to freehand build composite veneers for these teeth is going to be a lot of work. How am I going to judge the diastema closure, the length? In fact, I can go in and have the lab create for me a diagnostic wax-up. I then can make an impression with a VPS matrix using putty of this wax-up. And then when I'm placing my composite resins, I can now shape them to this stent that's placed on the lingual surface. I can build up using a stratification technique with composite, first using an opacious composite to avoid darkening of the incisal edge, then a body composite on the facial for the body shade, and then I can use some translucent composite for the incisal edge. I finish and polish one tooth at a time, and then I remove my dental dam, and I have my final restorations using a highly polishable nano hybrid composite. But without that stent, it would be difficult to duplicate these contours, to duplicate the proportion between the two centrals, the width and the lengths. So the PVS putty matrix really worked well to place that. And yes, I know we could have done porcelain veneers for these teeth. For this patient, they wanted a more affordable choice from using porcelain. But we're also using VPS stents to evaluate preparation design. And for this case, we're planning to place porcelain veneers from number 6 to 11. I have the lab create a diagnostic wax-up for approval by the patient, and so I can evaluate the final result that I'd like the lab to create. So from my diagnostic wax-up, I'm going to go in and make an impression of this wax-up. I'm going to section it along the incisal edge, and I'll take a look at how the diagnostic wax-up will help me determine my tooth preparations for the porcelain veneers. So here I've sectioned my impression of the wax-up, and I can see where the wax is relative to the teeth. I now go back to the mouth, and I'll notice that there are areas of the teeth, especially on the facials of the lateral incisors and the mesial facials of the two centrals, where I need to do very little preparation of the enamel. I'm going to remove that defective composite from the facial surfaces. It's going to guide me as to how I prepare the canines. Once I do my veneer preparations using the guide, following good principles, and you can see I've barreled into the proximal areas in order to have a wrap of the porcelain veneers, I can then make an impression. I'm using a VPS impression material for the veneers, and when I do veneer impressions, I am not packing any cord. Typically, you can do a bite impression, or you can use a tray for making the impression. I then go in and have the lab fabricate the veneers, and you can see how the veneers themselves are mimicking my diagnostic wax-up. How that I didn't need to prepare the facial surfaces of the centrals on the mesial facial, or very much preparation on the facial surfaces of the centrals in order to establish an aesthetic porcelain veneer. I'm also using VPS impression materials to simplify placement of fiber splints. And for this case, we have periodontally compromised mandibular anterior teeth, and I'm going to fabricate a rib-on periodontal splint. Now for this case, I've done my tooth preparations on the facial, I've cleaned the teeth, but I'm etching the teeth first before I do the block out. I'm etching, I'm rinsing and drying, and the teeth are dried, and you can see I've syringed impression material in between all of the gingival areas. This is so I'll minimize the composite when I'm placing the fiber splint. With the VPS material in place, I can now place my composite and my fiber ribbon into the composite. I can adapt it and shape it, and because I'm light curing the composite, I have the ability to minimize the excess, and I'm not getting any of the composite into the gingival embrasure areas, which are the most difficult areas to clean. The ribbon is pushed into the embrasure areas, and then I'm light curing. Removal of the VPS blockout shows that my gingival embrasures will need very minimal finishing. In fact, shaping the composite on the facial and the lingual, the result will need minimal finishing to start with. Here we're looking at my completed result, and I have a highly functional, aesthetically pleasing fiber splint placed for these mandibular anterior teeth. So you've been watching a Hints from Howard, a problem solver, where we've been looking at VPS impression materials reimagined, using them for other uses beyond just making impressions.